Hello, everyone. Welcome to our Zoom meeting. We're going to start. Welcome, and we have new fellows and we have the seniors. So we're going to see if we have a team ready to present. That would be great. Otherwise, we will just welcome the new fellows. And I was just talking to Dr. Omar about the abstracts. We have different projects that can be done, and we can work on them. So, Saja, did you have any feedback or response?
I'm sorry, Dr. Nadir. Did you hear me? I was talking.
I think
I'm so
you're.
sorry, Dr. Nadir. Yes, I didn't hear anything from the team, but I do have an old presentation if you would like me to share with the team.
Oh, that would be great. So,
Sure.
yes, go ahead, Dr. When
Of
you.
course, thank you.
So while Dr. Saja is preparing the slides, I'd like to welcome the new fellows, and I'd like to mention that during our Zoom meeting on Saturdays, we usually have some presentations, and these are opportunities for the fellows to practice their presentation skills, and they can develop the slides, they can pick up the topics. We usually have topics that are scheduled for the coming Saturday meetings in the future. But that doesn't mean we have to stick to the whole topics. We can modify, and it depends on the need and depends on the situation. Some of the topics will be knowledge-based. So we focus on geriatrics. So in other countries, during medical schools, you might not have exposure to the basics of treating older patients like here. So we focus on how we can manage them effectively. And that will be a unique opportunity for you if you have interest in applying for family medicine or internal medicine, for example. Or you can go ahead to apply for geriatric fellowship. Some of the programs accept applicants with some experience overseas, and they can bypass the residency. They can do 1 year or more in training for like geriatric medicine, as well as other programs like infectious disease or nephrology fellowship. They can accept also candidates with some experience overseas, and if they have green card or if they have US citizenship. So this is one of the topics. Usually we focus on something that you can apply in geriatric or internal medicine, family medicine. Then we have a dental group. They can also present some of the topics in dental medicine. And then we can also highlight some of the other like technology-based medicine in cardiology or other specialties. Then we will follow up with a second topic. Usually it's like a skill-based approach, either during the presentation, like using Canva, for example, or how to make slides, how to make posters, and so on. So how do you use the computer to express yourself and do things using certain tools. And then we can also talk about how to improve personal skills. So we focus on leadership, for example, skills, and other types of skills, teamwork, and so on. And the last part, we will focus on how you accomplish some of the research basics skills, like how to do graphs, how to analyze the data, how to write an abstract, how to write a paper, how to present a poster in a conference, for example, and so on, how to apply for a grant in the future, for example, if you become a research-oriented um, person, for example, in the future. So we have different aspects during the meetings, and in the future, if you have questions, let me know. Usually there is an assigned team that will handle the arrangement or organization of the topics, who will present what, and that team will have a leader. So we have different colors like green team, blue team, red team, and so on. And the next Saturday, for example, one of the team will be organizing that agenda, who will be presenting what topic. Some of the members or other team members might be interested in certain topics, so they can approach the team leader for that day and see if they can participate. The topic can be presented by one person or more than one. So one fellow can present the whole topic. We have, let's say, 4 topics. So we may need 4 presenters. Or the topic might be presented by 2 or more fellows. So it will be an opportunity to share and work as a team and divide the task. Who will present the first part, who will present the second part. And you can exercise the presentation between you guys before we actually present during the team or the Zoom meeting here. This will help you develop the skills of presenting confidently. If you have this skill, that's well and good. If you have some hesitation or some anxiety, that will help you overcome that problem or that situation. So in the future, the team leader will organize the Zoom meeting agenda and so on. If you have questions, let me know or let the team leader know. Sometimes the team leader will be the host for the Zoom meeting. Sometimes they can assign someone from the team to be the host, which means they just monitor the Zoom meeting. And if there is any questions, any comments in the chat, they can raise that for the speaker at the end, and they can conclude or basically organize the whole Zoom meeting without being me involved extensively in the meeting. That will help you develop the skills of how to organize a meeting, how to organize a conference, how to organize a talk. So it's an opportunity for the team leader or anyone who will be assigned by the team leader. So this is just some tips of how to work during this fellowship. So without ado, if Dr. Saja is available and ready, you can start.
Thank you, Dr. Nadir. Yes, of course, my pleasure. Can everybody see my screen?
Yes.
Okay, perfect. So today's topic is about the effect of psilocybin on hospice elderly patients. Enhancing quality of life through psilocybin-assisted therapy. We'll talk a little bit about psilocybin, a little introduction about that. It's just a second, please. Okay. The objective of the topic is to explore how psilocybin affects elderly patients in hospice care. It's very important to understand alternative treatment to improve quality of life and alleviate psychological distress, especially in patients receiving a diagnosis of end of life within 6 months. Psilocybin is a psychedelic compound found in over 200 species of what they call it now magic mushrooms. has been used for thousands of years by indigenous people in Mesoamerica cultures, such as the Aztecs, the Mastic people, use these mushrooms in religious and healing rituals and ceremonies. The mechanism of action of psilocybin, it's a prodrug, the metabolizing into psilocin, primarily targeting the serotonin, the subtype 5-HT2A receptors in the brain, altering perception, mood, and cognition. It also promotes neuroplasticity, helping the brain form a new neural connection, which underlies its therapeutic effect and introspection, facilitate emotional processing and acceptance. What is psilocybin? Psilocybin, just like we said, found in the magic mushrooms, has been used for rituals over like the past more than two thousands of years. Discovered recently by the Western science in the 1950 and isolated by Albert Hofmann in 1958. It gains popularity in the 60s counterculture, leading to its criminalization, unfortunately, because it got mixed with the other medication that they were used recreationally. Early research highlights its potential for treating mental health disorders, but legal restriction halted its progress. Uh, Recently, the research resumed in the early 2000s as at institutions like Johns Hopkins and Imperial College of London, revealing significant therapeutic benefits. Currently, even in the state, psilocybin been held on clinical trial right now, and it reduces symptoms of depression, especially the resistant depression, anxiety, PTSD, and just like we said, in hospice patient, in those patients who's waiting for 6 months, diagnosis of terminal illnesses. Also, it show promise in treating substance use disorder like alcohol and tobacco addiction. Psilocybin in the palliative care. Purpose in hospice is addressing terminal distress, anxiety, and depression. And by depression, just like we mentioned, it's like the treatment resistant depression. The goal is to improve emotional well being, enhance quality of life, and provide existential relief. Medicinal benefits in hospice care. When it comes to the benefits, first we go the anxiety and depression, which is the end of life anxiety that patients are experiencing during those last months of their life. Psilocybin has shown promise in reducing anxiety, depression, and terminally ill patients, including elderly hospice patients. Studies indicate that a single dose can lead to significant and sustained improvement in mood and anxiety, providing relief from the existential stress often experienced at the end of life. Uh, Pain management alleviate pain while primarily studied for its psychological benefits. Psilocybin effects on perception and cognition may also help in pain management by altering patients' experience of pain and reducing the emotional distress associated with chronic pain. Improved quality of life, enhancing well being. Psilocybin assisted therapy can lead to enhanced well being and improved quality of life for elderly hospice patients by fostering a sense of peace, acceptance, and connection. It can help patients find meaning and closure in their remaining life. The effects of quality of life. We're gonna talk in depth of the effect on quality of life. Psychological benefits, just like we mentioned earlier, when it comes to reduce the amount of anxiety, enhancing mood, and alleviating the stress, emotional benefit, increased sense of peace, acceptance, and well-being, social benefit, improved interaction with family and caregivers, a neurological effect, changes in the brain activity, enhanced emotional processing, and altered perception of self and life, improved emotional resilience. Um, when it comes to spiritual and existential relief, the patient will um, have a greater acceptance and peace of mind at the end of their life. Safety and side effect. Common side effect: nausea, transit anxiety, and altered perception. Safety profile: generally safe and controlled setting. It's important to consider individual health condition, of course. Ethical consideration, of course. First, they need to have an informed consent from the patient, fully informed of all the treatment and the side effect, and it's important to be uh, guided and supported. Like a patient will take it in a room, and the the doctor or um, the staff, the the staff from the doctor's office maybe accompany that patient, or maybe they just provide the room and they can check on him periodically. The legal status, it varies by jurisdiction. Important to adhere to legal and medical guideline according to the state, which state has been used at. Current research and application. Clinical trials right now. Clinical trials show psilocybin safety and efficacy in treating end-of-life anxiety and depression, and conducted in controlled environment with professional guidance. Regulatory status: although psilocybin remains a Schedule 1 as of right now substance in many countries, effort to reclassify it for medical use are ongoing. Some regions have decriminalized it, and the FDA has granted breakthrough therapy status for major depressive disorder. Practical considerations in hospice care. When it comes to the setting and support, the control environment is very crucial. Administration of psilocybin in the controlled supportive environment is crucial. Professional supervision ensures that the patient receive emotional and psychological support they need during the experience. Integration with existing therapy. Holistic approach is always the key. Psilocybin therapy should be integrated with other palliative care practices, including pain management, counseling, spiritual care, and to provide comprehensive support for elderly patients. In conclusion, psilocybin offers promising benefits for elderly patients in hospice setting, particularly in alleviating end-of-life anxiety, depression, and pain. As research continues and regulatory landscape evolve, psilocybin could become a valuable tool in enhancing the quality of life for terminally ill patients, helping them find peace and meaning in their final days. Thank you so much. If you guys have any questions, let me know. And those are the reference.
Thank you so much, Dr. Saja, for a great presentation. And any questions?
Thank you, Dr.
Dr. Saja, please raise your hand or go ahead. You can ask the question or any comments.
Thank you so much.
Thanks. Awesome presentation. So I want to ask you what we call engagement. How can I get you engaged in this conversation? So I have a question. Most of you are graduate from other universities, not in the US. So during your school years or after your graduation, did you know any or were you told about any of hospice medicine? if you did raise your hand, that would be great if you can just raise your hand if you knew something about hospice or hospice medicine when you were at medical school or after graduation before you came or till now. So Dr. Osman Ahmed, okay. So it seems like most of us know a little or we did not get education about the hospice or hospice medicine. So end of life in general. Isra also, okay. So 2 out of 40, 42. So why don't we touch on some of the basics of hospice medicine? So I'm gonna just teach you a little bit of the basics of hospice. And there is no problem with you guys and the education that you received. It's just we always focus on saving lives. We always focus on how aggressive we can do to help patients and their families. And at the end of life, sometimes it might not be the right thing to do. And I'm gonna use an example. So if there is a patient with advanced dementia, so they need some help with activity of daily living. By that, I mean they need someone to feed them. They need someone to dress them. They need someone to help them move or change from position to position, from bed to wheelchair, and so on. So these are the basic things that every one of us do on a daily basis. If they need all this help, that means they need significant assistance. And they cannot process mentally or make decisions. They are not able because of the advanced dementia. So if they are able to move around, that's well and good. So if they have an infection, let's say a pneumonia, we will use the same medicine that we teach you. You're gonna do the full examination, history taking, and assessment like X-rays and so on. And you will do like the treatment that we teach you, like antibiotics and so on. It could be oral, it could be IV, and the patient will be admitted to the hospital or go home on oral antibiotics. That's the medicine that we teach you. If a patient has appendicitis and with also dementia, so we will ask surgeon to look at them, and if they are able to tolerate the procedure, they can go in, take care of the appendix, and the patient will heal and will be better. They will be back to their baseline. Sometimes with dementia, that might not be always the case. So with dementia, for example, we will have the patient at a stage where they can do something out of the ADLs, let's say 3 out of 5. And with advanced uh, problem, they may not be able to process things or make decisions. So most of the time they will have someone to help that. And this progression of the dementia will go slowly, slowly, slowly. They will not be able to do the functions that they will be able to do. As we get older, we lose some of our strengths, for example. But with dementia, the decline will be obvious. Then comes an insult during this progression of the disease, like the examples that I mentioned. If they have a fall, fracture, they go to the hospital, they see the surgeon, orthopedic surgeon, say, I'm going to do the surgery. They fix the whatever broken bone, and the patient will come back. Usually with this insult, by an injury or an infection or something significant in their condition, will tip them a little bit faster than the usual progression of the disease. So the more they have this episode of infections or falls or fractures, operation, surgery, all this will add up on significantly declining their condition. And in all this, we teach you to take care of them. So if there is infection, you treat them. If they have fracture or need surgery, they can go through that. But at one point, the benefit of this aggressive approach might not be the same like the risk. We weigh what's the benefit, what's the risk. And if the risks are higher than the benefit, then here we will talk about what's the alternative. And here comes the approach, which is hospice care. For example, a patient with dementia might not be able to swallow the right way at the end of life. So they might have some regurgitation or some aspiration. If they have the aspiration, they may end up with pneumonia. We send them to the hospital, they give them the antibiotics, they come back. But if this is happening every now and then and it's recurrent, then the patient will decline, and his or her body might not be able to fight the infections anymore. At that point, we will talk about what alternative can we give this patient. Sometimes we talk about feeding tube, for example, if they are not able to swallow. So the feeding tube with patients with advanced dementia, there are some studies showed that if you put the feeding tube in and you continue provide feeding to the patient, and the patient will stay alive for some time. But when compared to other patients who did not put the feeding tube, they will last more or less the same time. So there is no significant of difference between putting a feeding tube or not putting a feeding tube in older advanced dementia patient when they compare the two groups. So from that, we focus on what the quality of life with patient on feeding tube versus patient on just hospice care. So patient with feeding tube, they still have the same risk as far as infection, aspiration, and pneumonia, and so on. So you are not minimizing that risk by doing the feeding tube, for example. This is one of the aspects that you can compare one approach to another. The question will come as far as the insurance here in the US. Who will pay for the hospice medicine? Because there are different insurance. They will pay for the regular type of medicine that we teach you, the aggressive approach, like Medicare, Medicaid, and so on, private insurance. They will pay for the patient to get the help they need in their home or office or hospital. Whatever approach, antibiotic, IV, fluid, ICU, and surgery, and so on. But for the patient who are at the end of life and they are suffering from this and that, and we see there is no point of using an aggressive treatment that will not benefit them, but at the same time, it may cause them to suffer more. So the insurance that covers hospice, they have their own way of assigning patients that they can pay for. So they have their criteria. So the main difference is they want to make sure the patient that they can cover is really sick and they need the hospice medicine care type of care. So they want a diagnosis. That means the patient, if left compared to other patients with the same condition in the past, the trajectory is that the patient will die within 6 months. So this is the first criteria, is that the patient will have a diagnosis, and that diagnosis, if left with the decline, that the patient will be expected to die within 6 months. And they need a statement by a physician who can document that. That's what's needed, one of the things. The second thing, they want to see there is significant symptoms indicating that there is a decline. So let's say a patient with dementia will live for years if they are able to eat and drink and walk around and so. So if they have early stage of dementia, they may not die within 6 months. But patients with advanced dementia, if they are not able to feed themselves, they're not able to swallow, they're not able to transfer from bed, they get infections, they get pressure ulcers, and they are losing weight, for instance, then losing weight by itself indicate that there is some decline. So the insurance wants you to document that there is a diagnosis, and number two, there is a symptoms indicating there is a decline. So there are a list of common diagnoses that the insurance will accept. One of them is, for example, stroke. One of them is advanced congestive heart failure. One of them is advanced COPD or chronic obstructive lung disease. Patient will be on oxygen. They are not able to move around with these conditions. More and more they get symptoms and so on. So there is significant decline. And the symptoms they want to see, for example, they have the patient, they are declining in condition, they are deteriorating, for example, or they are losing weight, as we mentioned, or they are not able to eat the amount of the food they eat is reduced. Let's say in the past they eat the whole meal 100%. Now they are eating 50%. In the future, they eat 25%. So there is a decline of oral intake, for example. So these are the two criteria that they did, in addition to the statement from a physician stating that the patient will die within 6 months. The physician might be right and might be wrong. So it's not a solid, like you are predicting this the accurate way, because everyone is different. So we built that statement on our experience in the past, like patients with this condition and with these symptoms and with the decline in condition, we expect them to die like the other patients that happened with them. Let's say in the past few years, we have COVID-19. So most of the patients, when they come to the hospital, they have certain criteria for them to be admitted to the ICU and treated. And most of the time, we understand which will benefit, which will not benefit, and will die. So ICU or intensive care physicians might have certain criteria that they apply, and then they say, oh, this patient might not do good. And they might be right most of the time, and the patient will die, as they said. And this experience, I had it when I was first year resident. I had my attending, she saw the patient in the ER, and I came and I saw the patient after she already spoke to the ER doctor. So she told me that patient is not going to make it. And I'm like, oh, how did you know? It was amazing because what happened, and the patient at that time, he has significant pneumonia. So the x-rays by itself showed some significant decline in that patient. Although the patient was young, but when we did the lab, also we have some testing showed that there are some significant decline in functional level as far as organ and so on. So she collected all the information and she predicted that the patient will not do well. So we admitted the patient to the ICU, and we tried whatever we have at that time, IV pressors and so on, oxygen. But within 24 hours, 48 hours, the patient passed away. So I'm like, okay, the physician with their experience and their findings on a patient can tell this patient will go that route or this route. So according to the experience, according to our knowledge in the past. But that doesn't mean we are 100% sure. Some of us will say, yes, the patient may die within 6 months, and some patients might not go that route. So you might see the decline, you might have the condition, but for some reason, they may pick up and improve, or at least they can, what we call plateau. They will be in that situation or that, so they dive down and then they flat on that status for some time. So they don't meet the criteria anymore as far as the insurance required the findings. So who will decide the patient to go into hospice? We have a couple of options. The patients themselves might be able to make that decision, or they can recognize that they are not doing well. So, for example, a patient with advanced cancer, especially pancreatic cancer or certain types of brain cancer, that's aggressive. So they know themselves that, oh, I was able to do this. Now, a month or two, I'm not able to get out of bed. I need all the help feeding myself and toileting and so on. So they recognize there is significant decline in a very short period, and they have the condition. So if we talk to them about, hey, you have this condition, and you notice the decline, and it's not going well. So I think we should consult hospice and they can be on board. So the patient themselves, they may be able to make that decision. Sometimes the family member or the guardian who make decision for the patient will make that decision. So we'll approach that from either the patient or the family members that so as physician, we need to recognize that we offer the option for the patient or the family or the guardian to make that decision. And the insurance will accept these conditions, the rules of statement from the physician, condition that's listed, and some symptoms to indicate that there is a decline. One of the symptoms, for example, is skin breakdown, what we call a pressure ulcer, but not any pressure ulcer. There is a significant pressure ulcer that's named Kennedy ulcer, which is named for a nurse in the past that she noticed all her patients who develop this type of ulcer, they will die within days of finding that ulcer. And the characteristic of that ulcer is that the helper or the family, they will say, the patient was doing fine yesterday. We cleaned the patient. She was fine. The skin was intact. We didn't notice anything. And today, when we change her, we see that there is a big ulcer, a deep ulcer. So it's like a hidden golf ball, or very deep ulceration of the skin. The muscles and everything under the skin is gone, and now the skin open, and we have this type of ulcer. It's called Kennedy ulcer, referring to that nurse. So if the family or the physician notice that that the patient is not eating, it's declining function, and now all of a sudden they have this type of ulcer, we can for sure say this patient is eligible for hospice, because the patient is expected to die within certain days or so, a short period of time. And I had some patients like that during my career. I saw some patients and the nurse will call me and we look at the ulcer, and it's a very significant ulcer. So we try to use the regular medicine as far as treating the ulcer, the wound, cleaning it, making the dressing the right dressing. And if there is infection, we give antibiotics. But at the same time, if the patient is declining, this is one of the symptoms indicates that the patient will decline further. So the insurance will make the decision, the final decision, that yes, the patient will be enrolled into hospice. So the hospice, they have their own team, as we have our own team. Let's say in the hospital or in the clinic or in the nursing home, you will have the physician, you will have a nurse, most likely you might have a social worker, a nurse aide, and so on, a dietitian. Someone will do physical therapy and so on. So in hospice, we have a similar team, but their function might not be similar. So for example, we have the physician. So the goal of the physician is to make sure that the patient in their last days or last months are as much as possible symptoms free. So we focus on the symptoms. So we address if there is a pain, we'll give pain medicine. We will try to achieve the goal that the patient will be as much as we can pain free. Sometimes we are successful, sometimes we are not. So that's the goal. And we understand that the patient might have side effects as we go up with the doses. One of the side effects, for example, constipation. So we need to give the pain medicine along with some laxative. So we minimize the side effects. And we try to address all the symptoms. As Dr. Saja just mentioned, anxiety at the end of life is a big thing. So we need to address anxiety, depression, shortness of breath. We will give them oxygen or bronchodilators, for example. Secretions, we give them some atropine or something to dry their throat at the end of life, for example. So all these are just measures to make them live a quality of life at the end of life, minimizing the symptoms. And the other team members, for example, the nursing staff will do the same nursing. And the social worker will try to also communicate with the patient and their families, address any issues or answer any questions. The therapy, however, is different type of therapy. In regular medicine, we focus on the function of the patient. We want to do therapy so that we can retain the baseline functional level that the patient is or was in the past. Let's say an older patient had a fall, fracture, went to the hospital, they had the surgery. They do therapy after surgery. The goal is to get them back walking again. Either with an assistive device like a walker or a cane or some assistive device, or maybe without any assistive device. So we want them to go back to the same level of function that they had before. In hospice, however, therapy might not focus on the functional level. They focus on the quality of life level. So we have music therapy, we have massage therapy, we have aroma therapy, we have pet therapy. Let's say a patient likes dogs, so we can bring a dog to visit them every now and then, once a week, twice a week, something like that, and so on. So the focus will be how to make their lives at the end of life more with quality, and they can enjoy it, and along with their family. And the whole approach or the support is not only for the patient. They can provide the support for the family members or those who are involved with the patient. And the care is not only while the patient is alive, like the regular medicine that we teach you. The care can extend even when the patient dies. The care will be continued to support the family members after the death of the loved one for up to 6 months, I think. So there are some periods they can offer some support to the family. So this is how we approach the hospice care medicine. In a nutshell, it's a very short difficult to explain everything, but I want you to know something related to hospice care or care at the end of life. And sometimes we offer what we call palliative care. Palliative is a totally different approach that can be offered with regular medicine that we teach you. Let's say a patient with lung cancer, they have chest pain. So we can continue with chemotherapy or radiation therapy and consult palliative team. They come and assess the patient for the pain. They will adjust pain medicine and so on. And the goal is to get rid of that cancer, for example. So there is no problem joining the palliative team with a regular team in a regular medicine, as we teach you in medical school. However, the palliative medicine team, they can also incorporate their approach to care for patients with hospice need. So they can collaborate with hospice care people or teams. And this is why some of the fellowship now, they may have palliative care medicine fellowship, or most of the time you will find it combined. It's palliative and hospice care fellowship. So if you are interested, after you do your internal medicine or family medicine, maybe you can join a fellowship in that regard, let's say in the future. But this is, in a nutshell, a summary of hospice care. So this just to tag along with what Dr. Saja mentioned or presented today. Any questions?
Yeah,
Thank you.
yeah,
Go ahead.
yeah. I'm just like I want to comment about the hospice care. Actually, I am from Libya, and as you know, maybe all of the Arabic cultures and maybe the religion takes part of this. I mean, like they might some people they say it's okay, some people they say it's not. But even about the hospice care centers, for, I will talk about Libya. We don't have hospice care centers in Libya, but like it depends on the like the family of the patient. If they want to keep him at the hospital, so they have right and they can keep him, and they will the patient that will occupy that bed and even the ICU or whatever, um, until he die or some or the people might they said no, we will take him home and we will take care of him. So and I don't know, it's like how to apply it in the Arabic cultures. Sometimes, especially in Libya, I'm just talking about Libya, maybe other countries different. But since we don't have um, this concept of the hospice care or hospice care centers or doctors are specialized in this situation, nowadays maybe people want like, like work like abroad, like United States or something like that. They become like aware that it's like this patient cannot, like if he had like cancer at old age and they said he cannot tolerate the chemotherapy and he will die maybe from the first second doses or whatever, they might like the family they will take wise decision and they will decide, okay, we'll take care of him until he die or something like that. Even in young people, especially in young people, if they have like end stage cancer, they will do whatever they can do, even they know he's in the end stage, he's gonna die, whatever they do, but they will still do whatever they can do. So it's, I don't know, maybe it's hard. Some, like maybe the cultures or something like that, it's play a role in this situation. So yeah, that's it. Just this is how I want to participate. Thank you, Dr. Nader, and thank you for the great lecture.
Thank you so much, Dr. Haifa, for your perspective and your input. Yeah, it's different in other countries, as she mentioned, and different in culture, different even within the same group. So, yeah, I totally agree. So, uh, any other questions or any other comments? Or as it,
Thank you.
go ahead.
Thank you so much, Dr. Nader. It was very informative, and thank you, Dr. Wafa. I'm sorry, Dr. Nader, we have two presenters would like to present their presentation. One short one from Dr. Wafa, and there's another one from Dr. Amna. It's a bit lengthy, so she want to know if you okay with that long presentation or not.
Oh, sure. And let me answer if Reem has a question. But sure, they can present if the second presentation is not like more than 1 hour, that will be good. So we have 1 hour, 7 minutes left. So we can do the 2 presentation, and we have some updates as far as poster presentation in the conferences from some of the fellows also. So Dr. Rim, please go ahead.
Yeah, thank you, Dr. Nadir and Dr. Saja, for this interesting subject. Yeah, I would ask, the hospice care in US, is it only eligible for those patients with life expectancy less than 6 months? And what about other elderly with expectancy of life more than 6 months? And also, I want to tell about my experience in Tunisia. So, with the patient with life expectancy, so short life expectancy, they just have hospice care, but at home with their families. So we don't have facilities for hospice care in Tunisia. So, yeah.
So thank you for the question, and thank you for sharing your experience. Yeah. So hospice care here in the US can be provided to the patient starting from the hospital when they have the diagnosis, or maybe they have a diagnosis at the clinic. So the hospice team will follow the patient wherever they are here in the US. If they are in the ICU, they can start with them there. If the patient and family decide to go to a hospice center or hospice house, then the patient will be transported there, transferred, and then the family and the hospice team will follow the patient there. It can be done in a nursing home, for example, or as you mentioned, it can be in the home of the patient or their family. So the hospice team will come and see the patient in their homes along with their family. So here, they follow the patient wherever the patient or the family decide to go. As far as the first question, the duration, as I mentioned, the insurance will decide the criteria. So they need a diagnosis. So they have a list of 10, 12 diagnoses, as mentioned, advanced cancer, advanced dementia, advanced stroke, for example. 10 diagnoses or so, or 15. They have one of them. If the patient meet the criteria, they check yes. And then they have some symptoms. Let's say weight loss. They have 10% of their weight lost in the 6 months. So they have a certain criteria, certain numbers that they go along with. So they have a nurse who will come evaluate the patient. They will go over the medical record, all the symptoms and so on, and they mark everything possible so that they can meet the criteria for the hospice here in the US. And if they meet the criteria, then the insurance will say, yes, approved. And then the hospice team will start taking care of the patient. If they don't, then they can ask palliative team to come and join the regular team and offer whatever they can as far as symptoms management, with the understanding that the patient may die, but because they don't meet the criteria for the insurance, the hospice insurance, they will not be enrolled in hospice. If I made that clear for you, I answered the question, let me know. Thank you.
Yeah, thank you.
So Dr. Saja, I think you mentioned Dr. Wafa.
Yes, Dr. Nadir. Dr. Wafa, she's ready with a short presentation, sorry. Dr. Wafa, are you here?
Yes, I am.
Okay.
Hello, everyone. And hello, Dr. Nadir. How are you?
Thank you.
And hello, everyone. Pleasure to speak to you all. And I'd like to thank Dr. Nadir for clarifying the difference between the palliative care and hospice. I found this really interesting. It's because the philosophy of palliative care and hospice, as it seemed to all of us, we who practice medicine outside of the United States, a little bit strange, but it's quite important, especially for geriatric. Okay, I'll be sharing my screen. Dr. Nadir, I have a question, since this was very interesting. From what you said, I understood that palliative and hospice. Palliative is not necessarily the patient has a life expectancy less than 6 months. Am I right?
Yes. So palliative is a different team, different approach. The goal of palliative is symptoms management, so alleviating of the suffering or minimizing the symptoms or the suffering of the patient. That can be applied to any patient. Actually, what we do right now, like if a patient had a fall and they have pain in their ankle, you some ice, you elevate the leg, you put some compression, you give them IV, or I mean ibuprofen or over the counter. All this are approach of palliative care. So you can apply it, and we teach you that in regular medicine. But they are focusing on symptoms with a significant effect on a patient. Let's say a patient with a cancer, they follow their oncologist. The oncology put on chemo. The chemo will have side effects. They're not able to eat or nausea, vomiting. So the palliative team will come and assist the oncologist as finding the right anti-nausea medicine, the right encouragement. Maybe they need someone to support them, feed them, or nutrition that they find less causing nausea. So the palliative team will be complementing the regular team of the aggressive approach, like the oncologist and so forth. So this is the big approach, and that approach can be added to the hospice team, or the hospice team will use that approach when they are treating patient with life expected to end within 6 months. So a patient with advanced dementia, not eating, not drinking, and so on, we expect them to die within 6 months. So the hospice will apply the same concept. If they have pain, they will focus on the pain. They have anxiety, they will focus on the anxiety. So they just put a bandage on the symptoms. They are not going to investigate what the problem, so they can fix it with IV antibiotics or surgery, for example, in hospice. But in palliative, they can work with the primary team, so they can figure out the problem and they can try to fix the problem while focusing on the symptoms, if that makes sense. So
yeah, it does make sense. Yeah, I see it now. Okay, my presentation is quite short. It is mainly targeted for the new fellows because we will be making like clarifications and definitions of few concepts that will be used regularly during the fellowship. So the title of my presentation today is Overview of Geriatric Rehabilitation. Dr. Saja, if you don't mind confirming my screen is clear for you and my voice is clear, yeah?
Yes, ma'am. Yes, ma'am. Both are clear.
Okay, the outline of my presentation, firstly, I'll be having a short introduction. Then I'll be speaking about key concepts in geriatric rehabilitation, type of rehabilitation providers, rehabilitation interventions, and rehabilitation settings. Okay. Rehabilitation is defined as a set of interventions designed to optimize functioning and reduce disability in individuals with health conditions in interaction with their environment. So this is the WHO definition of rehabilitation. It is a set of interventions designed to optimize functioning and reduce disability. And we'll be speaking what do we mean mainly by disability in individual with health conditions in interaction with their environment. Okay. The primary purpose of rehabilitation is to enable people to function at the highest possible level despite physical impairment. Rehabilitation includes a vast array of interventions provided by a diverse group of providers across the entire continuum of care. While rehabilitation may be provided to all age groups, the fastest growing population of persons requiring rehabilitation services is adult over age 65. This is because of the aging of the worldwide populations. Okay, it is estimated that 1 in 3 people today are living with a health condition that benefits to some degree from rehabilitation. It is now recognized that rehabilitation is a difficult, okay, and demanding task that seldom gives totally satisfactory results. The approach to rehabilitation should therefore begin with preventing rehabilitation. We should never allow rehabilitation to take place and afterward take up the uphill task of rehabilitation. Because rehabilitation itself, usually the services provided are costly. So prevention is better than cure. If we can prevent rehabilitation from occurring, this will be the optimum. Okay, improvements in both medical and rehabilitative care have helped to reduce the prevalence of old age disability. But it comes with a substantial price in demands for both medical and rehabilitation care. As I mentioned earlier, rehabilitation services are considered a little bit on the expensive side. Okay, so it is not one of the cheapest services, but it is a costly one. So we should try our best to prevent rehabilitation from occurring in the first place. But with elderly population, we will most probably need it because age will damage multiple organs in the body. The following areas of concern in rehabilitation have been identified, like medical rehabilitation, which is restoration of function, vocational rehabilitation, restoration of the capacity to earn a livelihood, social rehabilitation is the restoration of family and social relationship, and psychological rehabilitation, which is the restoration of personal dignity and confidence. Now coming to explaining what does disability mean, a model from the World Health Organization described disability as determined by an individual health conditions within the context of environment and personal factors. Rehabilitation services target the impairment as well as the person and environmental contextual factors that influence activity and participation. In another model, disability results from a mismatch between an individual capacity and task demands. Remediation of disability occurs through treatments that either increase individual capacity or reduce task demand. So there is a balance between the capacity and the demand, okay? Key concept in geriatric rehabilitation, these are interrelated conceptual areas specific to geriatric rehabilitation. We have the concept of frailty, the concept of resilience, and multimorbidity, and I'll be defining each one of these. Frailty refers to a person's physiological vulnerability related to age-related decline in the function of multiple organ systems. Multiple studies have shown measures of frailty are predictive of adverse health outcomes. For example, it predicts hospitalization, institutionalization. Frailty is commonly measured either according to a frailty phenotype based on key metrics, example, weak grip, slow gait, fatigue, or on a frailty index derived from totaling the number of deficits across multiple domains of health. Now coming to the concept of resilience. Resilience is related to frailty, but it's not a direct opposite. Resilience has been defined as one's ability to withstand or recover from functional decline after an acute or chronic stressor. It is thought to be a continuous spectrum across the entire lifespan, and as such can be thought of from both a physical and social perspective. Physical resilience in particular is an important new area of research in geriatric. Now coming to the last concept for today's, multimorbidity is a distinct concept and of critical importance to rehabilitation treatment planning, both with regard to therapies directed at a specific organ system impairments and with consideration of the potential interactive effects of the specific impairments in any given patient. However, effective treatment planning also needs to take into account the potential, the interactive effects of the various multimorbid conditions. For example, worse outcomes are seen among persons who have both impaired cognition and visual and/or hearing sensory loss, both because the cognitive impairment limits ability to learn coping strategies from the sensory impairment, and because of the loss of cognitive stimulation due to the sensory impairment. Okay, types of rehabilitation providers. Rehabilitation treatment by a provider in a single discipline is often sufficient for patients with uncomplicated conditions or with minimal disability. For example, like people with arthritis of the knee, they can benefit from only a physiotherapist and that's it. But for more complex or catastrophic disabilities, example, stroke, amputation, a multidisciplinary team of providers as part of an inpatient rehabilitation is optimal to address the interaction of multiple contributing conditions and contextual factors. As Dr. Nadir mentioned earlier, for example, a patient with a stroke, they may have a problem with swallowing, they have a problem with mobility, and they might be having depression. So they will need psychological rehabilitation, they will need physical rehabilitation, and sometimes they may have chronic pain and other problems. So it is a much more complex treating and rehabilitating such patients. Okay, examples of rehabilitation interventions. Rehabilitation in general measures may appear to be simple. They require planned and systematic actions. Medical, surgical, social, educational, and vocational, consistently over years with sustained counseling and health education. For this purpose, coordinated efforts by the departments of health, education, social welfare, as well as voluntary organizations are necessary. Of course, this depends on the context. If in the states, I'm not quite familiar how it is done in there, but I'm expecting, yeah, it's still must be a multidisciplinary, and the social workers and social department must be involved. Okay, examples of rehabilitation interventions. I just brought few examples. There are so many out there. For example, exercise. It is a physical activity is beneficial for reducing overall morbidity and mortality in older adults. It's also useful for chronic pain and a few other conditions. Assistive technology and adaptive methods encompass a diverse group of interventions designed to enable people with physical limitations to participate in a broad range of activities. There is the mobility aids, canes, crutches, walkers, wheelchairs, bathroom and self-care aids, prosthetic and orthotics. Environmental modification and universal design describe interventions and methods used to minimize the effects of the environment in exacerbating disability and to reduce accessibility, to enhance accessibility for all persons, irrespective of their abilities. There is a term called universal design. It highlights an overarching goal of enabling access for the widest possible breadth of physical abilities. However, the effects of medical conditions on physical function are variable among individuals. So sometimes it has to be tailored according to the condition. Okay, there is several modalities for pain. Several therapeutic modalities are available for the treatment of pain. There is, for example, nerve block, acupuncture, lots of them. Even exercise, as I mentioned earlier, can be a modality to treat chronic pain and to rehabilitate patients suffering from chronic pain. Community-based rehabilitation, this is a concept implemented through the combined efforts of the people with disabilities themselves, their families, organizations and communities, and the relevant governmental and non-governmental health, education, vocation, social, and other services. Rehabilitation in general tend to be, as I mentioned, resource consuming. So I think in India, they have some projects to rehabilitate patients with leprosy by using these services called community-based rehabilitation, where the patients themselves are involved in the implementation of the service. Okay, settings to do rehabilitation can be delivered in a wide variety of settings across the care continuum. Early mobilization beginning post-operative day one, the day of admission, or while in the ICU. Some research says that rehabilitation can start even if the patient is on a ventilator. It can shorten the length of stay and improve functional outcomes. Involvement of physical therapy and occupational therapy is a necessary component of hospital discharge planning, particularly for older adults in patients for whom there is concern about the ability to return home. Example limitations in self-care or mobility are present. Okay, there are multiple factors to be considered when determining an appropriate location for post-acute rehabilitation for a specific geriatric patient. Key factors to consider include their medical diagnosis, their functional abilities, pre-morbid admission and current, their medical stability, their cognition, therapy tolerance and motivation, types of therapy, services needed, psychological factors such as patient family preference, geographic location, third-party reimbursement. These are my references, everyone, and I'd like to thank you all for listening. Any questions?
Thank you so much, Dr. Wafa, for your presentation. It was very informative. If anybody has any question, please let us know. And after the questions, if Dr. Amna is ready with her presentation, she can share her screen. Thank you.
I have a question to Dr. Nadir, if I may.
Yes, go ahead.
It is not related to the presentation, but related to an info you mentioned earlier regarding fellowship application. You mentioned few fellowships, quite interesting fellowships for IMGs who finished their exams and did some overseas experiences. I'm wondering, after someone does the fellowship, the job market after a fellowship without residency in the United States, is it like they will find jobs easily, or is it competitive?
Good question. So my experience with fellows who were in our program and then they went to fellowship, most of them, they find it easier to get into residency. So it's kind of coming back from fellowship to residency. Usually you finish your residency and you go to the fellowship. So we have someone who did, let's say, geriatric fellowship, and now they are doing internal medicine residency. So it's easier that way. And it depends on your connection, and it depends on your chances of finding, most likely it's a second year. They want you to like hit the road, and sometimes they may need someone to cover that instead of accepting you to first year. It's not 100% secure, like you will be finding the same position in the same program, but most of the time, if they know you and you have connection with the same program, your chances will be higher when you apply to that program. But nevertheless, your chances compared to a person who just apply to residency, if you have a fellowship from a program here in the US, your chances are much better. So I hope I answered your question.
Yeah, you did, doctor. Thank you so much. Understood. Thank you.
You're welcome. Thanks. If Amna is ready, we can go ahead. And thank you so much, Dr. Wafa, for a great presentation.
You will.
Hello, everyone.
Hello, Dr. Amna, go ahead.
Okay. Can you see my screen?
Yes.
Okay. Okay, first I want to start by thanking everyone, thanking Dr. Nadir and Dr. Saja. I will be presenting about the management of hypertension according to the International Society of Hypertension that was published in 2022. Okay, so I'll talk about the definition of hypertension, blood pressure management, the diagnosis and diagnostic tests. Then after that, I'll talk about the hypertension-mediated organ damage, the exacerbators and inducers of hypertension. Then I'll talk into details about the treatment of hypertension according to the guidelines, followed by common comorbidities of hypertension and how to test these comorbidities. Then I'll touch briefly on some specific circumstances related to hypertension, such as resistance, hypertension, and hypertensive emergencies, briefly talking about ethnicity, race, and how it affects hypertension. And then I'll briefly show a comparison of different guidelines. Okay, to start, hypertension is defined by the guideline as basically the values that are shown in the table. Normal hypertension is defined as less than 130 systolic millimeter pressure of millimeter mercury, and diastolic value of less than 85 pressure of millimeter mercury. The high normal blood pressure is defined as a value that from 130 to 139 in systolic blood pressure, and or a diastolic pressure of 85 to 89. The high normal blood pressure is basically set in order to identify the patients that could benefit from lifestyle changes. The grade 1 hypertension is defined as a value of 140 to 159 of systolic blood pressure and 90 to 99 of diastolic blood pressure. Grade 2 hypertension is defined as a blood pressure that's 160 or more, and or a diastolic blood pressure that's 100 and more. These are the classification or the measurements that we can use in case of office blood pressure measurements. As we know, some patients take ambulatory measurements that are measurements at home or just outside of the office in general, or home blood pressure management. Those have their separate values set by the guideline. As we see, blood pressure was defined as 140 or more for the systolic value and 90 or more for the diastolic value. The ambulatory blood pressure is defined as 24-hour average. As we know, the ambulatory is basically blood pressure taken by devices that could be attached to the body that take multiple readings throughout the day. So the 24-hour average is defined as 130 and more or 80 or more. That's the criteria. For the daytime or awake average, when it's 135 and more or 85 or more, this is what these are the values that are concerning or that are defined as hypertension. The nighttime or sleep average is lower because in general we tend to have lower blood pressure while we sleep. So it's 120 or more systolic or 70 or more diastolic. The at-home blood pressure management also, they have a lower standard than that of the office, which is 135 or more systolic and 85 or more diastolic. Now, it's important to know that these readings does not diagnose hypertension with a single reading. So you have to have multiple readings in order to diagnose hypertension. As I said, the high normal blood pressure is intended to identify individuals who could benefit from lifestyle interventions and who would receive pharmacological treatment if there are compelling indications. The individuals who are identified with confirmed hypertension, that's grade 1 and grade 2, should receive appropriate pharmacological treatment immediately. Now, these are some of the important things to know while taking blood pressure. Firstly, you should check the condition, then the position of the patient, the device you're using, the cup size and position, the protocol, and the interpretation. The room in which you're taking the blood pressure for the patient should be comfortable and it should have a comfortable temperature, so it should not be very hot or very cold. Before the measurement, make sure that the patient did not smoke, that the patient did not take caffeine. It can give a false high reading, or it can increase the blood pressure temporarily. Patient shouldn't have exercised for 30 minutes. They should have an empty bladder and remain seated and relaxed for about 3 to 5 minutes. Neither the patient nor the staff should talk before, during, and between the measurements. In regards to the position of the patient should be sitting with their arm resting on a table with mid-arm at heart level. So make sure that the mid-arm and the device, if you're using a device that uses mercury, make sure that it's at the level of the heart. The back of the patient should be supported on a chair, legs uncrossed, and feet flat on floor. There was a figure, but unfortunately, I did not include it in the presentation. Regarding the devices, you could use a validated electronic upper arm cuff device, which is basically the electronic blood pressure device, or you can use a calibrated oscillatory device that is the aneroid or hybrid mercury sphygmomanometer. It's a classic sphygmomanometer that uses mercury. The cup size should be appropriate to the individual's arm circumference, so it shouldn't be very big or very small. A smaller cup gives overestimations, and larger cups give underestimations of blood pressure. Okay, so basically the manual oscillatory devices, the inflatable bladder of the cup must cover 75 to 100% of the individual's arm circumference. So it shouldn't be short or small. It should cover the arm 75 to 100% of the individual's arm circumference. The protocol is that at each visit, 3 measurements should be taken with 1 minute between them. The average should be calculated of the last 2 measurements. So you would disregard the first measurement and take the average of the last 2 measurements. If the first blood pressure is less than 130/85, no further measurement is required. Right? So if the first reading is already within the normal limit, you should do not take further management, or you're not required to take further management. It's very important to take note of the protocol. The blood pressure interpretation should be taken of 2 to 3 office visits that equal or are more than 140 divided by 90 millimeter mercury. This is what indicates hypertension. As I said earlier, you do not diagnose hypertension from a single visit. So 2 to 3 office visits with the specified protocol, taking 3 measurements. If all of that gave a result of 140/90 or more than that, this patient can then be diagnosed with hypertension. Okay, so we have some varieties of hypertension that I would like to discuss. Isolated systolic hypertension is the first one. As the name suggests, it is when you have systolic hypertension and the diastolic blood pressure is normal. So the systolic blood pressure would be 140 or more millimeter mercury, and you would have a low, actually not normal, a low diastolic blood pressure of less than 90 millimeter mercury. Another term is the white coat hypertension. It's when the patient has elevated blood pressure only in the office. Excuse me. The blood pressure would be normal on ambulatory reading or home blood pressure measurement. This basically could be due to nervousness and anxiety that the patient gets when he sees the doctor, when he's afraid of getting hypertension or high blood pressure. So the anxiety leads to transiently elevated blood pressure. It's important to identify this because you do not want to diagnose the patient falsely because of the transient anxiety period they have, and later get the patient on medication that could potentially damage their system or that are not required. Masked hypertension is the opposite of white coat hypertension. It is when there is non-elevated blood pressure in the office, but elevated blood pressure outside of the office, which is during the ambulatory reading or home readings. So that's why a hybrid, this is not a part of the guideline, but that's why a lot of some doctors deem it important to have both in-office readings and outside of office readings. Blood pressure measurement plan according to office blood pressure. Okay, so these are the plans that we should take if the patient has certain types of readings. If the reading is less than 130 over 85, and it's therefore normal, remeasurement should be taken within 3 years, 1 year in those with other risk factors. So if the patient has other risk factors, diabetes, chronic kidney disease, and so on, the reading should be taken within 1 year. If the patient has a borderline, or let's say the high normal levels, and the levels that are included in grade 1 hypertension, that's from 130 to 139, grade 1 and high normal, and from 85 to 99 diastolic. If possible, it should be confirmed with out-of-office blood pressure measurement. There is a high probability of either white clot or masked hypertension. The patient, this alternatively should be confirmed with repeated office visits. Okay, so if the patient has a measurement or measurements that are more than 160 over 100, this could be confirmed within a few days or weeks. This patient is not to be sent for measurements after a long period because they probably have hypertension. Okay. As I said earlier, the diagnosis should not be made on a single visit, office visit. The diagnosis, however, could be made with a single visit if the blood pressure is 180 over 110 millimeter mercury or more, and there is evidence of cardiovascular disease. So this is the circumstance in which we can make the diagnosis on a single visit. Okay, so usually what do we do? 2 to 3 office visits at 1 to 4 week intervals, depending on the blood pressure level, as we discussed earlier in the previous slide. These are required to confirm the diagnosis of hypertension. Okay, so once we clinically diagnose hypertension, we should move to diagnostic and clinical tests because, as we know, hypertension affects multiple systems. First, we have the blood test. We should check the sodium, potassium, and serum creatinine levels. We should also check the estimated glomerular filtration rate. If available, we can do a lipid profile and fasting glucose to screen for hypertension. Urine test, we should do a dipstick urine test because the kidneys are highly susceptible to get affected by hypertension. We should also do a 12-lead ECG test to detect atrial fibrillation, left ventricular hypertrophy, and ischemic heart disease, all of which are either caused by hypertension or hypertension is a risk factor to get them. Some additional tests that can be used: echocardiography, which can be used to assess multiple things: systolic, diastolic dysfunction, aortic coarctation, and also left ventricular hypertrophy. Carotid ultrasound to check for atherosclerosis and stenosis. The kidneys could be tested by ultrasound and Dopplex and other means. Liver function tests could also be used, could also be taken. Endoscopy is also a test that we can use to check for retinal changes, hemorrhages, bapilledema, and so on. Brain CT and MRI also can be used to check for ischemic or hemorrhagic brain injury due to hypertension. Ankle brachial index can also be used to check for peripheral artery disease. Further testing can be used in case of secondary hypertension for, of course, cholesterol, plasma-free metanephrine for pheochromocytoma, and so on. Okay, next section is hypertension-mediated organ damages. Okay, hypertension-mediated organ damages are defined as structural or functional alterations of the arterial vasculature and or the organs supplied that is caused by elevated blood pressure. So basically, the organs are supplied by vessels, arteries. Those arteries are damaged by the high blood pressure, which leads to structural or functional damage in the organ itself. So the end organs include the brain, the heart, the kidneys, central and peripheral arteries, and the eyes, all of which we discussed in the testing that could be used. But those are the end organs that could be affected or are usually affected by high blood pressure. So routinely, we should do serum creatinine and estimated GFR, dipstick urine test, and 12-lead ECG. These are the routines. Furthermore, the brain could be affected in case of TIA, transient ischemic attack, or stroke, for which we can use MRI to detect white matter lesions. The heart could be affected in the form of left ventricular hypertrophy, as we discussed. 12-lead ECG could be used to detect or to screen, and then two-dimensional transthoracic echo could be used to accurately assess the left ventricular hypertension. Kidneys can be affected. So basically, kidney disease can be caused by hypertension, and it can be a cause of hypertension. So it's important to check the renal function test using the routine investigation, serum creatinine, and estimated GFR. Other means as well, dipstick or albumin creatinine ratios. The arteries for atherosclerosis could be checked by carotid ultrasound. That's either for the carotid, so by ultrasound for the carotid, or for the lower limbs, we can use the ankle brachial index. The eyes, fundoscopy, especially in patients with grade 2 hypertension and patients who experience hypertensive urgencies and emergencies to detect retinal hemorrhages, microaneurysm, and double edema. Okay, next slide. We are briefly mentioning the exacerbators and inducers of hypertension. So in the guideline, it was stated that non-steroidal anti-inflammatory drugs, combined oral contraceptive pills, antidepressants, acetaminophen, which is widely used, could be exacerbators of hypertension. Other medications include steroids, antiretroviral therapy, etc., etc. Purple and other substances can also exacerbate or induce hypertension, including alcohol, mahuang, which is a herbal pure substance, ginseng, also at high doses, licorice, St. John's wort, and hindi. Okay, so after we gave an introduction, let's dive into the bulk of the guideline, which is the treatment of hypertension. We are going to talk about the lifestyle modification, then the pharmacological treatment, and then we are talking about tips to enhance adherence to antihypertensive treatment. So as we all know, the first line in hypertensive management is lifestyle changes, which include, according to the guideline, the cessation of smoking, regular exercise, losing weight, salt reduction, healthy diet and drinks, lower alcohol intake, lower stress, reducing exposure to air pollution as well. Okay. So the guideline follows this steps. So first we'll start by establishing the diagnosis as per the criteria after multiple readings. and then we will start the lifestyle advice. After that, if the lifestyle advice does not work, we are going to classify the patient into grade 1 and grade 2. Please bear in mind that sometimes the patient is diagnosed with grade 1 or grade 2. So in which case, we are going to give the lifestyle advices, but we are going to give that and the grade 1 and grade 2 management immediately. So we're not going to just wait to see the result of lifestyle advice. So the grade 1 is from, as we defined earlier, we should give immediate drug treatment in high-risk patients or those with cardiovascular disease, chronic kidney disease, diabetes mellitus, or HMOD. Okay. So the essential or the recommendation is to see if the patient has limited drug availability or not. If there is limited drug availability in those at lower risk, we should supply lifestyle intervention for 3 to 6 months. Okay. If the blood pressure is still not controlled and where possible, still not controlled, start drug treatment. Okay. So basically, if there is the medication is not available, and if the patient is from 50 to 80 years of age, start the drug medication. Okay. If the patient is still has high blood pressure after 3 to 6 months of lifestyle changes, and if the patient is from 50 to 80 years of age, immediately start drug management. Otherwise, if the risk is lower and there is no drug availability, wait for 3 to 6 months to see the effect of lifestyle management or intervention. Okay. So this is the optimal kind of recommendation, and the recommendation in the case of availability of drug, if there is drug is available. So drug treatment in low to moderate risk patients without cardiovascular disease, chronic kidney disease, or diabetes mellitus, or HMOD after 3 to 6 months of lifestyle intervention. Okay, if blood pressure is still not controlled. So it's basically more or less similar, but we will give treatment in this case for patients with risk factors, the mentioned risk factors. If the patient does not have those risk factors, even if in the case of availability of drugs, it's recommended just to go to lifestyle changes. Okay. So as a summary, grade 1, if the patient is elderly and if the patient has comorbid disease or risk factors, give the drug treatment. In grade 2, we're immediately going to give drug treatment in all patients. Okay, so the guideline gave a simplified classification of hypertension risk according to additional risk factors. It classified it as low, moderate, and high. I'm not going to go into details about this, but it's important to kind of check the risk factors of multiple patients and try to give a more individualized or relatively individualized treatment plan according to the risk. Okay. Okay, so moving on to the drug treatment. So essentially, a targeted blood pressure reduction by at least 20 over 10 millimeter mercury. Ideally, to get the blood pressure down to less than 40 over 90 millimeter mercury should be the aim for the blood pressure control within 3 months. So this should be our goal. It's important to put our goal in mind while giving the treatment and to follow up in order to follow up as well with the patient. The target is to reduce blood pressure by at least 20 millimeter mercury systolically and 10 millimeter mercury diastolically, ideally to less than 140 over 90 millimeter mercury within 3 months. Now, if the patient, which is important for us, if the patient is 65 years old or older, The target, if the blood pressure target should be less than 140/90 millimeter mercury, which is higher than in younger patients, if tolerated, because as we know, older patients tend to be frail, unlike younger patients. However, consider an individualized blood pressure target in the context of frailty, independence, and likely tolerability of the treatment. So this goal is optimally a bit loosened and individualized in elderly patients. Now, ideally, the drug treatment should be evidence-based in relation to morbidity and mortality prevention. Ideally, once daily regimen, which provides 24-hour blood pressure control, should be used. However, this is to be individualized to patients. Treatment should be affordable and/or cost-effective relative to other agents. So if a certain medication that's recommended is not available in the country, or if other medications are usually alternative medication are usually more feasible and more accessible, they should be considered. Treatment should be well tolerated, and evidence of benefits use of the medication in population to which it is to be applied. As we know, Black population usually benefits from, or as we're going to discuss later, some medications tend to work better with certain ethnicities. Okay, so this is the drug. Okay, so basically, ideally we should, as we said, use single day combination therapy. For step 1, we would start with dual low dose combination. That's A plus C, which is A is ACE inhibitor or angiotensin receptor blockers. An example of ACE inhibitor is captopril. The medication is ending with pro. And I'm just giving examples. I'm not specifically talking about which specific medication is better to use. The ARB or the angiotensin receptor blockers are basically the medication that ends with the sartan, so low sartan, and so on. So step 2, we should follow the sequence. So if this dual low dose combination does not work, we will move to step 2, which is basically giving the full dose of the combination. We started with the low dose of ACE inhibitor and ARB. Then we should move to giving the full dose of the combination. Step 3 is adding a medication, which is triple combination. We will give the patient the ACE inhibitors, the ARB, and the thiazide-like diuretic. An example is metronidazole. Again, I'm just giving examples, not specifically the preferred drug for management. And then after that, if the patient, the goal that we set earlier, which is getting the 20/10 reduction within 3 months is not met, we would move to step 4. In step 4, this is where we would define the patient as having resistant hypertension. So here we're going to use the triple combination plus spironolactone or other drugs. So like amlodipine and so on. Okay, so in step 4, where the patient would have resistant hypertension, we would give ARB, ACE inhibitor, ARB, thiazide-like diuretics, and spironolactone. Okay, so use whatever drugs are available with as many of the ideal characteristics as possible. Use free combination if single pill combination are not available or unaffordable. Use thiazide diuretics if thiazide-like diuretics are not available. Use alternatives to DHP and CTB, calcium channel blockers, if these are not available. So this basically this is where the guideline kind of provides the drug treatment and the options you can use and how to move on with the steps of treatment. Okay. Kindly consider that beta blockers at any treatment step is added when there is a specific indication for its use, which is heart failure, angina, post-MI in post-MI patients and patients with AFib. Okay. Make sure to evaluate adherence to antitherapy treatment at each visit and prior to escalation of antihypertensive treatment. So, check adherence before escalating to the next step, because sometimes the failure of reaching the goal or the aim of medication could be due to non-adherence rather than the drug not working. Here are some strategies to improve medication adherence. Reducing polypharmacy is one of them, which could also translate into using once-daily dosing, linking adherence behavior with daily habits, providing adherence feedback to patients, letting the patients take their own blood pressure, or just doing home blood pressure monitoring in general, reminder packaging of medication, and some other strategies that could be used. Okay, now I'm going to talk briefly about the common comorbidities of hypertension. The first is coronary artery disease. I'm not going into the details. The other is stroke, heart failure, chronic kidney disease, and COPD. Diabetes is also a common comorbidity, and lipid disorders as well. Now, in general, in case of these comorbidities, we should definitely consider get the patient to have lifestyle changes as recommended, but it should also be noted that blood pressure should be lowered if at 140/90 or less, and treated to a target of less than 130/90. And of course, this is a bit increase in elderly patients, so the mark is less than 140/80 in elderly people. And this, of course, is to make sure not to exacerbate the comorbidity or lead to complications. Okay, we should also check and treat the cholesterol accordingly to the set of guidelines. We should check the fasting serum blood glucose, as we know, because diabetes is one of the comorbidities. The serum, the urine, we should also check. We should also give antiplatelet therapy in patients who have cardiovascular disease for the secondary prevention. Okay, so I'm going to touch briefly on specific circumstances. Now, resistant hypertension, as we said earlier, is having a blood pressure of 140/90 in a patient treated with 3 or more antihypertensive medications at optimal or maximally tolerated doses, including a diuretic after excluding pseudoresistance, which is poor blood pressure management techniques, white coat effect, non-adherence, suboptimal choices of medications and antihypertensive therapies, as well as substance or drug-induced hypertension, like the inducers and exacerbators that we mentioned earlier, and after we exclude secondary hypertension. So basically, it's when the patient has a persistently elevated blood pressure that's more than 140/90 in case and no apparent reason. This affects around 10% of hypertensive individuals. For these patients, consider screening for secondary causes, optimize the current treatment. As we said, I add low dose of spironolactone and refer the patient to specialist centers. Okay, hypertensive emergencies. The hypertensive emergencies include malignant hypertension, which is a severely elevated blood pressure of more than 200/120, associated with advanced bilateral retinopathy that is seen in the context of hemorrhages, cottonwool spots, and babyledema. Another hypertensive emergency is the hypertensive encephalopathy. As the name suggests, it's when the patient has a severe hypertension with encephalopathy, so lethargy, seizures, cortical blindness, that's in the absence of other explanation. Hypertensive thrombotic microangiopathy is when the patient has severe blood pressure elevation associated with hemolysis, thrombocytopenia, in the absence of other causes, and in which the hemolysis and thrombocytopenia improved in the presence of in the context of lowering blood pressure therapy. And the last one is hypertensive urgency, which is marked elevation in blood pressure without evidence of target organ damage. So we do not have here organ damage, evidence of target organ damage, but right? Okay. Hypertensive urgency is when we have a marked elevation of blood pressure without evidence of target organ damage. Okay. Okay. So this is the guidelines, basically a recommendation to treatment of each of the previous conditions, that details on which drug to use. Okay. Lastly, we're going to talk about ethnicity, race, and hypertension. Now, Black population develop hypertension and associated organ damage at younger ages. They tend to have a higher frequency of resistance in nighttime hypertension, and they have a higher risk of kidney disease, stroke, heart failure, and mortality than other ethnic groups. This increased cardiovascular risk may be due to physiological differences, including a suppressed renin-angiotensin-aldosterone system, altered renal sodium handling, increased cardiovascular reactivity, and also early vascular aging, leading to Black population developing large artery stiffness earlier than other ethnicities. Whenever possible, annual screening for hypertension is advised for adults 18 years and older. The first-line pharmacological therapy is recommended as a single pill combination, including a thiazide-like diuretic plus calcium channel blocker or calcium channel blocker plus in ARBs, which is different from the previously discussed first step of treatment. Among renin-angiotensin system inhibitors, ARBs may be preferred as angioedema is about 3 times more likely to occur with ACE inhibitor among Black patients. Now, as we know, angioedema is a side effect that's known with the ACE inhibitor. It's also known that it's more likely to happen to Black patients, 3 times more likely to happen to Black patients who are taking ACE inhibitors. Okay, so briefly comparing the guidelines, just to give you a picture of the number of guidelines that are present, we have the American Heart Association or the American College of Cardiology 2017 guidelines, the European Society of Cardiology or the European Society of Hematology in 2018, the International Society of Hypertension in 2020, which is the guideline that we just discussed, and some other Asian guidelines. As we can see, the values differ. For example, here, this high normal, as we can see that sometimes you would have, basically different naming, grade 1, stage 1, different. Here we have grade 3. Here in other guideline, it's graded as grade 2. So there are different guidelines made for different regions, which is good in the sense that it could further individualize the treatment according to the specific population that the society focuses on. Okay, this is another example of basically the definition of normal, abnormal, and increased hypertension in different societies in both clinic and home measurement. As you can see, the American College of Cardiology has a different value than the European Society of Cardiology. Okay. Now, there is a very nice summary of the diagnosis, evaluation, and treatment and monitoring. That kind of summarizes the important points and the essential points that the guideline recommends. That's present with the figures that could be checked for easy access. I just wanted to show a picture of that. These are the resources. Thank you very much for the opportunity. Please feel free to ask me if you have any questions. Thank you very much, everyone.
Thank you so much, Doctor, for your great presentation. Dr. Nadir, do we have time for another presenters, or are we short on time?
Perhaps next week or the week after. We have some updates, and it's 4 o'clock, so almost. So I'm sorry, but thank you so much for your offer and the one who is trying to present. But we'll be happy to have you in the coming weeks, so you can contact the leader for any of the coming weeks and see when you are available and they are available. Thank you. We have a couple of fellows for the updates, and if anyone, please raise your hand and jump in. In the meantime, thank you so much, Amna, for great presentation. I really appreciate your help and step up, all of you. So thank you.
You're welcome. You're welcome. Thank you, Dr. Nadir.
Dr. Haifa, go ahead.
Yes, thank you, Dr. Nader, for giving me this opportunity, and thank you for all the presenters for today's really good presentation. My question is regarding the poster. Is there any specific like template that we have to use, or as you know, I'm not resident yet or follower, so I'm just wondering, and all the participants, the doctors who participate with me, most of them actually they are out of the United States, and so I'm just wondering what, how to identify our abstract regarding to school, medical school, or society, or whatever.
So in the past, we used templates from previous presentations. So we have templates that you can use, and you can. So, but there is no limitation. You can use any templates if you come across something that you and your team prefer. So it's free to you to decide. But we are here to help. If there is a request for a template that's already made, we can offer you.
Okay.
We have, yes.
Yeah, thank you. And another thing that in my abstract, when I posted that it doesn't have any, for example, graphs or anything. So when I want to do the poster, can I add a paragraph or more information than the one that I sent it to them, or I have to restrict to what information that I have sent it to them? So I just put this information in the poster.
I think if it clarify your ideas, yes. It's they don't limit you to the same words that you submitted, because you have room to expand. When you submit the abstract, you have a limited number of either character or words. So you can explain yourself the way you want, but don't make it contradict what you submitted to them.
Yeah, of course, yeah. And is it okay if I submit it without graphs or because it's it's a little bit complicated topic. So
you can have the graphs, and they don't have a problem with graph imaging anything that you want to add in the abstract. I don't think there is any limitation for that.
Yeah, okay, thank you very much. I really appreciate it. And then I will email you, so just send me the template that you have, so I might use this one, and I will discuss with the group. Thank you very much. I really appreciate your time, Dr. Nader. Jazakallah khair.
You're welcome. Thank you, and good luck. Anybody else? Go ahead. Dr. Faiza, thank you.
Yes, hello everyone. Good evening, good afternoon. So I'm Faiza. We had NAPKIRG presentation last week. Alhamdulillah, we presented two of our posters. Unfortunately, I could not be there personally due to visa issues, but my husband was there and he would like to share his experience. I think it'll be benefiting for the other members of the audience who want to prepare a poster as well. And as for Haifa, I also want to inform her that poster can be, if you want, colorful and descriptive. There's no word limit on the poster presentation. You can, it's a very visual presentation of the information, so it's better if you add more graphs or pictures and make it appealing. And we can have templates from Canva as well as other Microsoft PowerPoint presentations as well. So, and now I'll hand over to my husband for his experience.
Hello, hi everybody. I'm Syed. I'm one of the. Well, I'm actually a resident at Rochester Unity Hospital. So I was helping Faiza and her friends from TGRF with the poster. So I went to this conference, NAPKIRG. It was a good conference. There was a lot of people, not just medical students and residents and attendings, but there was a lot of ancillary stuff like physical therapy, social work. So it was a good experience. As far as the posters are concerned, I took a walk around and saw the other posters as well. Most posters were literature reviews. Some posters were based off of small surveys, and some of them were based off big data sets. Like I think in Canada, in their state called Ontario, they have a big data set of their patients. So there were some posters which did data analysis from those big data. Now, as far as the posters are concerned, we had I was involved in one of the posters, which was use of artificial intelligence in age-appropriate cancer screening, and I think we had a very good response. People were, intrigued about what are the latest AI tools which are out there in the market, and what AI tools are FDA approved for cancer screening. And there was another poster from another group where my wife was involved. It was a relatively simple type of topic, which was like role of vitamin D in low back pain. It was a literature review. People liked the outline of the poster. It was very simple, and we had a big graph explaining the results. So not a lot of text, but uh, because of the flow chart, people liked that. So overall, I think it was a good experience, and I'd encourage anyone who could present would do so. And thanks, Dr. Nadir, for helping all the applicants and letting me share the experience.
Thank you so much. Really appreciate your time, and thank you for sharing the experience, and wish you all the best.
Thank you. Have a good day.
Thank you. Thank you, Dr. Faiza. Dr. Neda, when you have a minute, go ahead.
Hello, can you hear me?
Yes.
Hi, my name is Nida, and I'm here to share my experience at the annual NAPKIRG conference that was in Quebec City. So I had the opportunity to present two posters, and it was my first time presenting at a conference, and it turned out to be a great experience. To be honest, I was a little nervous at first, but it was really nothing to be nervous about. People would stop by to read the poster, ask questions, or they'd ask to hear about the topic directly from me. And the interactions led to some pretty engaging discussions, and I got to hear people's thoughts, ideas, and feedback. Like I said, I presented two posters, and the first day it was a project titled Breaking the Chain, an app to stop chain smoking. And this project really seemed to resonate with a lot of the attendees. We got to discuss a lot of the app's features, as well as the role of technology in advancing healthcare. And people shared that they thought it would be really beneficial and that they knew people who could really benefit from the app. And I got some great feedback and ideas for improvement. On the second day, I presented our project titled Medication Adherence and Associated Risk Factors Among Patients with Diabetes Amidst War in Northern State Sudan. And this project really drew interest from attendees that have expertise on diabetes care. And so they got to share their thoughts and experiences related to the topic. I also got the opportunity to explore the other posters that were there, and I got to learn about some innovative projects that other people are working on. And so I got some really, I participated in some really interesting discussions. I also got to meet healthcare professionals and, professionals working within research. And so that really broadened my understanding of the field, and I got to gain new perspectives. But beyond the presentations, it offered a wide range of sessions, the conference as a whole. And so you really get to explore things that you're interested in. I'm particularly interested in healthcare disparity, so I got to attend some sessions on that. All in all, I'd say it was a pretty great experience. And I wanted to thank Dr. Nadir for the guidance and support that he's provided the teams throughout the process. And if anyone has any questions, please let me know.
Thank you so much again, Dr. Nada, and your team, along with other teams as well. Thank you. Any questions for Dr. Faiza, Dr. Nada, or any of the presenters? Please raise your hand if you have questions. So NAPCREC stands for North America, basically primary care medicine group. And this is a combination between physicians in Canada, US, and Mexico, I think. So basically, any research that you are doing for helping care providers in healthcare regarding primary care, you can present that. And there are two types. One is an ongoing research. So if you have a research project that is not finished, you have the idea and you started the project, you are still in the process of collecting the data or analyzing the data, you can submit your project as an ongoing abstract, and they can accept that if it's a good idea or they love your title and the area. And the second part is the part where I think all these presenters from today, they participate and present their work, which is a complete project. So if you have a research that's finished and you are already ready to present, so you submit the abstract, and if they accept it, you're going to go and present the whole poster, for example. I think the benefit, in addition to what mentioned by the presenters today, when you go to attend these meetings or conferences, you will get engaged with other, and you will see other people, other researchers, their work. You will have more ideas. You will have some feedback, maybe critics or maybe ideas, new directions. And the best part, I think, is the connection. So you can know or come to know some other connection in the either research field or clinical field, or even you can make connections with program attendings or directors. Some of the program directors attend these conferences. So if you come across some of these, maybe you will be making connection and see. So if they see you work, they see you, they may have an opportunity to look at your CV and so on. Thank you so much. Any questions? Any comments, suggestions, ideas? Go ahead, Dr. Motamin. Go ahead.
Yes. Thank you for the opportunity. I just had a little inquiry I wanted to make.
Go ahead.
I recently signed up to the Geriatric group, so I'm really a bit new. So I'm trying to. I signed up for one of the projects. Okay, it was number 73, I think. It's about the barriers to. I'm not sure of the title. I don't remember. It was on Telegeriatric, the project's page. It was number 73, I think. So I signed up, and there's I think another person who signed up also for it. And I just want to know, like, because it says you should submit a draft. Is it after the formation of the team, or yeah, this one? Yes. So
Good question.
yes.
Thank you so much for the question. So I added this about 10 last 10 poster ideas or abstract ideas. And the idea is to work on them and submit them to the AGS, the American Geriatric Society. They have a conference coming and they are accepting abstracts. And in the past, our experience when we submitted some of the poster or the abstract, they accepted the work that's completed along with the work that not completed. So we had a research project that was ongoing, and we did not finish analyzing the data and finalizing the conclusion. But they accepted that, and they gave us an extended deadline. So let's say they gave us 2 months to finish the data and put up the conclusion and resend the abstract. So at that time, they accepted an abstract with a title, with introduction, background, and the method part, but the results part and the conclusion part were not completed. So they were ongoing. Unfortunately, I didn't know they changed their rules. So when I added these projects or ideas, I thought we can do the same. So any one of you can work with the team to work on getting an abstract that's an ongoing. You get the idea, background that can be done in a short time, along with the method. Most of the review, systematic review, will use certain tools and keywords and database. So it's not going to be a big of a deal to come up with an idea and a title, and you can submit an abstract, and the data will be collected and analyzed. And I think within a month or two, you will be able to finish the project and resubmit if they give the deadline extension. But unfortunately, in their website, they mentioned that this time they wanted a complete research project. So the abstracts are supposed to have all the component: introduction, method, results, and conclusion. So for you guys, I thought it's going to be helpful, but for the AGS, at least this round is not going to be of help. However, I think you can work on the project. Let's say Motamin and 73, Yasir, you can create a team. If you have some in the WhatsApp group, you can ask if any other fellows interested. You can work on getting this project running. So what you want to do is you contact some of the senior fellows, anyone who presented a systematic review in the past, like some of the presenters of today. They attended some of the conferences and they know how to, or other seniors, they know how to do the review of system or some systematic review. So you can start the work. One of you will be the leader for the project, and the other can be the submitter, the one who will start writing the document, make sure the conference that they want to participate in, and they can meet the criteria, they can meet the deadline and submit and be the communicating or corresponding author, and the other team members can work on other tasks of the project. So I wish you all the best, and I hope I answer your question. And for all fellows who are interested in any of the topics here, it's all can be done either in systematic review or other types of, let's say, survey or something like that. So look around, see if you have some ideas. And Dr. Saida and Faiza and Dr. Neda, if you can log into the NAPCREC website and see if you can also find any topics that presented there that might be of interest to the group here, and you can share that abstract or a number of abstracts that presented, and we can take a further step out of these posters or abstract. Sometimes they will have the direction, the new research ideas out of that project. So we can either use the same idea with some modification, similar to the diabetes poster. It was done in Sudan. Maybe we can do one in Libya, in Tunisia, in India, in Pakistan, or anywhere. Qatar, for example, we can use the same method and the data will be unique to that area. For example, if we only change the location or the cohort or the population for that study, if you know what I mean. Thank you so much.
Thank you, Doctor, for the explanation. It was really helpful. Thank you.
Thank you.
Thank you so much, Dr. Nadir.
Thank you.
Thank you. So if there's no more questions or ideas or comments, I'd like to thank you so much, Dr. Saja, and all the presenters from today and all those who participated in conference and the updates. Thank you all. And I'd like to thank who attended today and those who will come and look at the and watch the recording later. Thank you. We'll see you next week. If you have questions, reach me by email, contact me, call me, text me. I'll be happy to help as much as we can. I wish you all the best and have a wonderful day or night. Assalamu alaikum.
Alaikum salam. Assalamu alaikum.
Thank you, Dr. Nadir.
Thank you so much.